Let's set the stage with some numbers that matter. Nearly 2 out of every 3 adults over the age of 60 in the United States have high blood pressure. That's roughly 65%, and the vast majority of those people are taking at least one medication to manage it. Many are taking 2, some are taking 3 or 4 stacked together. Now here's the part that doesn't get talked about enough. Your kidneys, those 2 fist-sized organs tucked against your lower back, are responsible for filtering about 50 gallons of blood every single day. They remove waste, balance your fluids, regulate minerals, and help control your blood pressure naturally. They are extraordinary little machines, but they are also extraordinarily sensitive to changes in blood flow and chemical balance. And that sensitivity increases as you age. After 60, your kidneys have already lost some of their filtering power. That's normal. It happens to everyone. Your kidney function at 65 is not what it was at 35, even if you've been perfectly healthy your whole life. The medical community measures this with something called your GFR, your glomerular filtration rate. Think of it as a score that tells you how well your kidneys are cleaning your blood. A healthy GFR sits above 90, below 60, and doctors start paying closer attention. Below 30, you're in serious territory. So what happens when you add certain medications into an aging kidney system that's already working harder than it used to? That's exactly what we're going to explore. Not to scare you, not to tell you to flush your pills down the toilet tonight. Absolutely not. But to arm you with information that could genuinely change the trajectory of your health in the years ahead. Let's get into it. The first category we need to talk about isn't technically a blood pressure drug on its own, but it becomes a kidney destroyer when combined with one. And millions of seniors are doing this combination every single day without realizing the danger. I'm talking about NSAIDs, non-steroidal anti-inflammatory drugs. That's ibuprofen. You know it as Advil or Motrin. That's naproxen, sold as Aleve. These are medicines you can buy without a prescription at any pharmacy or grocery store in America. They're in your medicine cabinet right now, probably. You reach for them when your knee aches, when your back flares up, when arthritis makes your fingers stiff on a cold morning. And on their own, used occasionally, for a short period, they're generally manageable for most people. But here is where it gets dangerous. When you take an NSAID regularly, and regularly can mean just a few times a week, while you are also taking a blood pressure medication, particularly a diuretic or an ACE inhibitor or an ARB, you create what nephrologists call a triple whammy effect on your kidneys. Each drug individually changes the way blood flows through the kidney's tiny filtering units. Stack them together, and you're essentially squeezing the blood supply to your kidneys from multiple directions at once. Let me paint you a picture so this makes sense. Imagine your kidney is a garden hose with water running through it. A diuretic, that's your water pill, something like hydrochlorothiazide or furosemide, turns down the overall water pressure. It's doing its job, pulling excess fluid out of your body. Fine. Now your ACE inhibitor, lisinopril, enalapril, ramipril, relaxes the blood vessels leaving the kidney, which changes the pressure inside the filtering system, also doing its job. But now you wake up with a stiff shoulder and you pop 2 ibuprofen. That NSAID constricts the blood vessels going into the kidney. So now you've got reduced flow going in, altered pressure inside, and reduced volume overall. Your kidney is starving for adequate blood flow, and it can't filter properly. Do that once? Your body probably compensates. Do that 3 times a week for 6 months? A year? 3 years? You are silently eroding your kidney function in a way that may not show up on blood work until significant damage is already done. A study published in the British Medical Journal found that the combination of a diuretic, an ACE inhibitor or ARB, and an NSAID increased the risk of acute kidney injury by 31%. 31%. And the risk was highest in the first 30 days of combined use, meaning the damage can begin fast. Here's what frustrates me. Most seniors are never warned about this. Your cardiologist prescribes the blood pressure medication. Your orthopedic doctor says take ibuprofen for joint pain. Your primary care physician may not even know you're combining them because you bought the ibuprofen over the counter and never mentioned it. Nobody connected the dots. And your kidneys paid the price. So, what should you do? First, and I cannot stress this enough, tell every single doctor you see about every medication you take, prescription and over the counter. Write it all down on a piece of paper and bring it to every appointment. Second, if you're on a blood pressure medication and you need pain relief, ask your doctor about acetaminophen, that's Tylenol, as an alternative. It works differently and doesn't carry the same kidney risk when used at appropriate doses. Third, ask your doctor to check your kidney function regularly. A simple blood test measuring your creatinine level and calculating your GFR takes minutes and costs very little. If you're over 60 and on blood pressure medication, this should be happening at least once a year. If it's not, request it. You are your own best advocate, remember that. Now, this second one is going to feel contradictory, and I need you to sit with that discomfort for a moment. Because the truth is often more complicated than a simple good or bad label. ACE inhibitors and ARBs are among the most widely prescribed blood pressure medications in the world. ACE inhibitors include drugs like lisinopril, enalapril, benazepril, and ramipril. ARBs include losartan, valsartan, irbesartan, and candesartan. You've almost certainly heard of at least one of these. You might be taking one right now. And here's the complicated part. These medications are actually considered kidney protective in many situations. For people with diabetes, for people with protein in their urine, for people with early chronic kidney disease, ACE inhibitors and ARBs can slow the progression of kidney damage. They've been proven to do this in large clinical trials. Doctors prescribe them specifically for this purpose. So how can they also damage kidneys? Context, dosage, age, hydration. And the thing nobody talks about enough, the tipping point. Let me explain. ACE inhibitors and ARBs work by relaxing blood vessels, which lowers blood pressure throughout the body. Inside the kidney, they specifically relax the efferent arteriole. That's the tiny blood vessel leaving the kidney's filtering unit. When that vessel relaxes, the pressure inside the filter drops. In a well-hydrated, otherwise stable patient, this is beneficial. It reduces strain on the delicate filtering membrane. But in a 68-year-old who caught a stomach bug and has been vomiting for 2 days, or a 74-year-old who doesn't drink enough water because she's afraid of having to use the bathroom too often, or an 81-year-old who just started a new diuretic on top of his existing ORB, that pressure drop inside the kidney becomes too much. The filtering system essentially stalls, waste products build up in the blood, creatinine levels spike, and if nobody catches it quickly, you can end up in the emergency room with acute kidney injury. This is not rare. This is not theoretical. Emergency departments across the country see this pattern regularly, especially during summer months when older adults become dehydrated more easily and during flu season when illness causes fluid loss. A large-scale analysis published in the American Journal of Kidney Diseases found that ACE inhibitors and ARBs were involved in approximately 15 to 20% of all drug-induced acute kidney injury cases in patients over 60. 15 to 20%. That's a staggering number for a class of drugs that hundreds of millions of prescriptions are written for each year. Now, and I want to be very clear about this, I am not telling you to stop taking your ACE inhibitor or ARB. Please do not do that without talking to your doctor. Stopping these medications abruptly can cause dangerous blood pressure spikes. The goal here is awareness, not alarm. What you should know is this. If you are on an ACE inhibitor or ARB and you get sick, any illness that causes vomiting, diarrhea, fever, or reduced fluid intake, call your doctor immediately and ask whether you should temporarily hold your medication. Many physicians now teach something called sick day rules for these drugs, similar to what diabetic patients learn about insulin adjustments during illness. If your doctor hasn't discussed sick day rules with you, bring it up at your next visit. Also, hydration matters enormously, not excessive water intake. That can cause its own problems, but steady, consistent fluid intake throughout the day. 6 to 8 glasses of water, more if it's hot outside or if you've been physically active, Your kidneys need that flow to function properly, especially when ACE inhibitors or ARBs are in the picture. If you're over 60 or caring for an elderly loved one, this information could genuinely be life-saving. A simple conversation with a doctor about sick day protocols could prevent a hospital admission. Share this video with someone you love. It takes 2 seconds and it might matter more than you think. And monitor your blood work. If you're on an ACE inhibitor or ARB, your potassium levels and kidney function should be checked within 1 to 2 weeks after starting the medication or after any dose change, and then regularly thereafter. High potassium, a condition called hyperkalemia, is another serious side effect of these drugs that becomes more likely as kidney function declines. Symptoms of high potassium include muscle weakness, tingling sensations, nausea, and in severe cases, dangerous heart rhythm changes. If you experience any of these, seek medical attention promptly. The third medication category is one that almost every senior has encountered at some point, whether they realize it or not: loop diuretics. The most common one is furosemide, which you probably know by its brand name, Lasix. Others in this group include bumetanide and torsemide. These are powerful drugs. They work in a specific part of the kidney called the loop of Henle, hence the name loop diuretics, and they force the kidney to excrete large amounts of sodium and water. Doctors prescribe them for fluid retention, heart failure, swollen ankles, and yes, blood pressure management. When someone is carrying excess fluid and their heart is struggling to pump efficiently, furosemide can be a lifesaver. Literally, it pulls fluid off the lungs, reduces swelling, and eases the burden on the heart within hours. So, where does the kidney damage come in? Volume depletion. Plain and simple, furosemide is incredibly effective at removing fluid, sometimes too effective. And when too much fluid leaves the body too quickly, or when the dose is too high for what the patient actually needs, the kidneys lose the blood flow they depend on. The technical term is prerenal azotemia, but let's skip the jargon. What it means is that the kidneys aren't failing because they're broken. They're failing because they're not getting enough blood delivered to them. Like a car engine running without enough oil. The engine itself might be fine, but without lubrication, it seizes up. In older adults, this chain of events unfolds with alarming ease. Consider a 72-year-old woman named, let's call her Margaret. Margaret has mild heart failure. Her doctor puts her on furosemide, 20 milligrams daily. She's also on lisinopril for blood pressure. Summer arrives. Margaret tends her garden every morning, sweats more than usual, and doesn't increase her water intake because she's already running to the bathroom every hour from the furosemide. She skips lunch a few days because her appetite drops in the heat. Within 10 days, she feels dizzy standing up, fatigued, a little confused. Her daughter brings her to urgent care. Blood work comes back showing a creatinine level nearly double her baseline. Her kidneys are in acute distress. Margaret's kidneys weren't diseased, they were dehydrated, starved of adequate blood flow by a combination of a strong diuretic, summer heat, inadequate fluid intake, and an ACE inhibitor that was further reducing pressure inside the kidney's filtration system. Every single piece of that puzzle was manageable, if someone had been watching. This scenario plays out in doctors' offices and emergency rooms thousands of times per year. The elderly are disproportionately affected because their thirst mechanism is blunted, meaning they simply don't feel as thirsty as younger people even when their body desperately needs water. Their kidneys also concentrate urine less efficiently, so they lose more water per trip to the bathroom. Long-term use of loop diuretics at higher doses has also been associated with chronic interstitial nephritis, a form of ongoing, low-grade kidney inflammation. A study in the Clinical Journal of the American Society of Nephrology documented accelerated GFR decline in elderly patients on sustained high-dose furosemide compared to those managed with lower doses or alternative approaches. Practical steps you can take if you're on a loop diuretic. First, weigh yourself every morning. Same time, same clothes, same scale. This is the single most reliable way to track fluid status at home. A sudden drop of 2 or more pounds overnight suggests you may be losing too much fluid. Report it. Second, know the signs of dehydration: dry mouth, dark urine, dizziness when standing, muscle cramps, confusion. These aren't just getting old, these are warning signs. Third, ask your doctor if your diuretic dose is still appropriate. Bodies change, seasons change. What was the right dose in January might be too aggressive in July. Fourth, if you're also on an ACE inhibitor or ARB, which is a very common combination, be extra vigilant about fluid balance because you now have two medications affecting kidney blood flow simultaneously. Let's step back and look at the full picture because I know we've covered a lot of ground. 3 medication categories: NSAIDs combined with blood pressure drugs, ACE inhibitors and ARBs during vulnerable moments, loop diuretics causing volume depletion. 3 different mechanisms, one shared outcome: reduced blood flow to aging kidneys that can't afford to lose it. Notice the common thread running through all 3 scenarios. It isn't that these medications are inherently evil. Every single one of them saves lives when used correctly. The danger lives in the gaps. The gap between your cardiologist's prescription and your over-the-counter ibuprofen habit. The gap between a dose adjustment in March and a heat wave in August. The gap between a strong diuretic and a glass of water that never got poured. Those gaps are where kidneys get hurt. And closing those gaps doesn't require a medical degree. It requires attention, communication, curiosity about your own body, the willingness to ask one more question at your next doctor's visit. Let me leave you with 5 concrete actions you can take this week. 1. Make a complete medication list, every pill, every supplement, every over-the-counter drug, and share it with every healthcare provider you see. Keep a copy in your wallet. 2. Ask your doctor when your kidney function was last checked. If it's been more than a year, request a basic metabolic panel. It's a simple blood draw. 3. If you're on an ACE inhibitor, ARB, or diuretic, ask your doctor about sick day rules. Write them down. Tape them to your refrigerator. 4. Commit to consistent hydration. Not excessive, consistent. A glass of water with every meal, a glass between meals, more when it's hot or you've been active. Make it a habit like brushing your teeth. 5. Stop buying NSAIDs without thinking twice. Before you reach for that bottle of ibuprofen or naproxen, ask yourself, am I also on a blood pressure medication? If the answer is yes, call your doctor before taking it, every single time. Your kidneys have been working for you silently your entire life, 60 years, 70 years, 80 years, filtering, balancing, cleaning, adjusting. They never asked for recognition. They never sent you a warning notification. They just worked. And they deserve your protection now in this chapter of life when they need it most. The medications you take are tools, powerful tools. And like any powerful tool, they require respect, understanding, and careful handling. You wouldn't hand a chainsaw to someone without explaining how to use it safely. Your medications deserve the same consideration. Talk to your doctor, not with fear, but with confidence. Print this information out if it helps. Bring questions, bring your medication list, bring your curiosity. A 5-minute conversation could add years of healthy kidney function to your life. That's not an exaggeration. That's what the research shows over and over again. You've spent your whole life taking care of other people. Your children, your spouse, your parents before them, your co-workers, your neighbors, your community. Now it's time to take care of you. And that starts with knowing what's going into your body and what it's doing once it gets there. If this video helped you understand something you didn't know before, hit that subscribe button. We put out new senior health content regularly, and every single video is designed to give you clear, honest, practical information you can actually use. Share this with your spouse. Text the link to your adult children, post it in your church group or your neighborhood chat, because the person who needs to hear this most might not find it on their own. Drop a comment below and tell me, are you currently on any of the medications we discussed today? Have you ever had your kidney function checked? I read every single comment, and your experiences help other viewers feel less alone in navigating this. Take care of those kidneys. They've been taking care of you longer than you know.